name is Bradley End, and this is Resident Perceptions of a Dedicated Emergency Department Sonographer. We've retained our initial title slide. I am currently affiliated with the West Virginia University Department of Emergency Medicine. This project was completed in collaboration with several members of the department, including Ms. Stacy Grimmett, Dr. Clara Kraft, Dr. Kim Quidado, and Dr. Joseph Minardi. A brief introduction to the West Virginia University Department of Emergency Medicine. We are a tertiary care facility in rural Appalachia with approximately 50,000 ED visits per year. We have 30 categorical EM residents, 10 from each PGY year 1 through 3. As far back as 2006, the department contained only a single Sonosite 180. We had no dedicated ultrasound faculty, no formalized ultrasound training in the residency program, and no PACS system to document and save images. The current ultrasound director, Dr. Joseph Minardi, was appointed in 2007. It became apparent over time that some of the workload and workflow of the ultrasound director could be performed by a dedicated sonography education faculty member. We hired our first SEFM in 2011. The candidate search highlighted those candidates who had extensive clinical and educational experience. Initially, the SEFM's role was predominantly focused on the educational mission of the department, teaching both faculty and residents and students of all levels. However, over time that role expanded to include administrative duties, operational duties, technical and research-related responsibilities. The objectives of this study were to determine the resident perceptions of the SEFM, or Dedicated Emergency Department Sonographer, in regards to the number of scans they performed during a shift, their confidence in image acquisition and interpretation with the sonographer at bedside, the usefulness of feedback that they received during supervised scans and afterwards in form of written feedback, and their ability to decrease reliance on comprehensive ultrasound services and ionizing studies such as X-ray and CT. We created the survey instrument using Qualtrics. There were 11 questions, 10 Likert scale questions, and 1 freeform question regarding various facets of the ED sonographer's roles. The instrument was distributed via email and anonymous links to all residents within the program. Reminder emails were sent at days 3, 5, and 7, and the survey was closed after 1 week. In addition to the resident survey, in an attempt to collect objective data, we performed a retrospective chart review. A 12-month period was evaluated between July 2018 and June 2019. We reviewed both completed notes and images to try to determine the number of scans that were performed by residents on an ultrasound scanning shift when the sonographer was present and when the sonographer was not present for their shifts. We were able to identify 5 resident scan shifts with only a faculty assignment within the ultrasound department and 6 where they were assigned to the sonographer with no ultrasound faculty present. We compared the number of organ systems scanned with and without the ED sonographer to get our final numbers. The results from the initial survey had a fairly good response rate of 80%, a total of 24 responses, and a representation of 8 from each PGY year. The next few slides go on to document the response frequency using the Likert scale to various questions that were included in the initial survey. As you see here, residents generally reported that the presence of the sonographer increased both the number of exams performed during a clinical shift and the exams performed during a scanning shift. In regards to feedback, the vast majority of residents agreed or strongly agreed that the sonographer provided helpful real-time feedback. The majority also agreed that helpful written feedback was provided by the sonographer. Regarding confidence in image acquisition and interpretation, the majority of residents agreed that the ED sonographer improved both acquisition and interpretation confidence of images obtained at the bedside. While there was not a majority that felt that the presence of the ED sonographer decreased the ionizing radiation studies ordered in the department, a majority of residents did feel that it decreased their use of comprehensive or radiology-performed ultrasounds. Here is a graphical representation of the scan shifts with the ED sonographer on top and scan shifts without the sonographer on the bottom. Once again, this was obtained through retrospective chart review, where we reviewed both the notes and the images to see the total number of body systems that were captured during these scans on assigned shifts. As you can see, there is a significant difference in the number of organ systems scanned by the ED intern assigned to the scanning shift when a sonographer is present versus when they are not assigned to a shift with the sonographer. Looking back on the data that was already presented, when we combine the strongly agree and agree Likert categories, 79% of residents reported that having a sonographer on a clinical shift increased the number of scans performed, while 83% reported the presence of a sonographer on a scanning shift increased the number of scans performed. 96% reported that the presence of the ED sonographer increases confidence in image acquisition and in image interpretation. 67% of respondents either agreed or strongly agreed that the presence of the ED sonographer decreased their utilization of comprehensive ultrasound services, while 50% reported that the presence of the ED sonographer decreased the use of studies involving ionizing radiation. 96% of our residents reported that the real-time scanning feedback from the ED sonographer was helpful. Looking back on the total number of organ systems scanned by an intern either assigned to an ED clinical scanning shift with a sonographer versus with the ultrasound faculty, we found that interns who were assigned to a shift with a sonographer averaged 17.5 plus or minus 3.5 organ systems scanned on a shift, while interns who were assigned only to the ultrasound faculty without the sonographer present averaged 5 plus or minus 2.75 organ systems scanned on a scanning shift. In conclusion, the resident perceptions of the presence of a dedicated ED sonographer are generally favorable. The presence of an ED sonographer increases the resident's self-reported number of scans per shift, increases confidence in image acquisition and interpretation, and may decrease the utilization of comprehensive ultrasound services and, to a lesser extent, ionizing imaging. And retrospective review corroborates that the presence of the ED sonographer is correlated with an increased number of scans performed, at least in our intern population. There are a number of limitations to this study. The number of scans performed by the interns on the shifts was obtained by a retrospective chart review process, which was complicated by scheduling discrepancies, and there were a small sample of days due to overlap between physicians assigned when the sonographer was already on the schedule. The exams performed by interns on an urgent or emergent basis for patients or for educational purpose may not have been saved in the PACS, and no notes may have been documented, and so we may have underestimated the number of scans performed. Regarding next steps, since the distribution of the survey, we have devised scanning log sheets to monitor scanning volumes of students and interns while on shift. We continue to improve the feedback mechanisms for residents both on and off shift, and we've encouraged the ultrasound faculty to seek out scans for learners while on shift. That concludes our presentation. Any questions, comments, concerns, or quandaries can be directed to bradley.end@hsc.wvu.edu. Thank you very much for your time.